Okay, so the objectives of today's training, it's to refresh the memory of our providers on the scheme's benefit package, the medicines list, and most importantly, the tariffs operation manual. I know that we've all been providing services to members of the scheme, but we felt that with recent happenings, it's possible that we may not even know some of the things that are covered. And so this is just to meet us at that point of need and make sure that we are all on the same page as to what is covered, how to even find out if we are not too sure as to what is covered. And I believe that if we go through these 3 bullet points, we'll be able to get some understanding and appreciation of what the NHIS has in store for its members with regards to its benefit package. Next, please. Okay, so a little background of the scheme. Before the scheme happened, how was healthcare financed in Ghana? I think between the 1950s and 1970s, there was free healthcare for all in the country. Then it moved to the period of the structural adjustment program between 1970 and 1983, where a minimum token was required of all patients who visited healthcare facilities. Then the 1983s to 1990s, the period of what we used to call the cash and carry, where user fees were in operation. Then the period of 1990 to 2003, a number of community-based mutual health insurance schemes started in the country. And then we all know it's culminated in 2003 with the inception of the National Health Insurance Scheme that has been in operation till date to finance healthcare of all residents in the country. Next, please. So a little bit about Ghana's NHIS. Our vision is to be a model of a sustainable, progressive, and equitable social health insurance scheme in Africa and beyond. I think we've been doing that for a while. Flagship program, people are learning from us, and it's something that we all ought to be very proud of and protect with every bit of our might. The mission of the scheme is to provide financial risk protection against the cost of healthcare for all residents in Ghana. And our core values, we espouse to operate with integrity, accountability, empathy, responsiveness, and innovation. Next, please. Okay, so characteristics of the scheme. It was designed as a social intervention program. And as I spoke on its mission, it was to provide financial risk protection against healthcare expenditure. It's financed primarily through taxes, and it is intended for all residents in the country. Healthcare providers for the scheme cuts across ownerships and levels. When I say ownership, I mean public, private, faith-based, and levels from tertiary right down to the community-based CHIPS compound. As at December 2020, our membership stood at 52% of the population, about 16.3 million. Next. So how does NHIS function? We are under the Ministry of Health. The ministry provides stewardship, policy, and regulation for our operations. And then as a purchaser, we are supposed to pay for the claims that are submitted by providers who provide the services to our registered members. The subscriber or member is also a player in this, in that a section of them have to pay premium, and then, of course, they have to use the services for which the provider would put in claims for us to pay. So this is, in short, those who are involved in how the scheme works. Next. Okay, so now I'll move on to speak on the benefit package of the scheme. If you are a member of the scheme, what are you entitled to? Next. So the NHIS Benefit Package is a service package to be rendered to members of the NHIS by credential providers. It is derived from Act 852. At the inception of the scheme, it was Act 650, but that has been reviewed to Act 852 now. The benefit package of the scheme is not explicitly stated, but the exclusion list is explicitly defined in a legal instrument. The legal instrument that we use now is what was designed for Act 650. The new one for Act 852 is still in draft form, yet to be intended to. The benefit package as a whole, as to what a member will be entitled to receive, it has not been reviewed comprehensively since the launch of the scheme in 2003. There have been changes to additions here and there of medicines and so on, and we'll look at that in a moment. But the benefits as it stands has not been reviewed since 2003 when the scheme was launched. Next. Okay, so this shows what services are covered. Outpatient services are covered, and under outpatient services, we have general and specialist consultation and reviews, investigations, laboratory tests, x-rays, ultrasound scans, MRIs, and all the medicines that are listed on the NHIS medicines list. Same goes for inpatient services, general and specialist care, investigations, lab works, x-rays, ultrasound scans, and MRIs, and the medicines on the list. Then some detail as to we also cover oral health services, we cover eye care services, and then the free maternal policy, which was embedded into the operations of the scheme. So maternity services are covered, antenatal, normal and assisted deliveries, cesarean section, postnatal care, and care of the newborn. And of course, emergency services. There are some conditions that may be excluded in the bigger exclusion list, but when it presents as an emergency, the services are covered. So we have medical and surgical emergencies, including brain surgery due to accidents, and then pediatric, obstetric, and gynecological emergencies, road traffic accident injuries, industrial and workplace accidents, and then dialysis for acute renal failure. Next, please. So this is what the exclusions are, as stated in the LI of the scheme. The NHIS does not cover aesthetic treatments or dialysis for chronic renal failure. You recall from the previous slide that we do cover dialysis for acute renal failure, but we don't cover the chronic one. We don't cover organ transplantation or orthoptics, cancer treatments, except cervical and breast cancer. So breast and cervical cancers are covered under the NHIS. VIP ward accommodation, mortuary services, heart and brain surgery, other than those resulting from accidents, will not be reimbursed by the scheme. And if a medication is not listed on the NHIS medicines list, it will not be reimbursed for. Medical examinations for visa applications, driving licenses, and so on is not covered. And then if you have to do some diagnosis or treatment abroad, your membership will not extend for those treatments outside the country. The rest of them I have highlighted with red, and it's for a reason. Immunizations, treatment for TB, HIV treatments, mental health treatments, family planning are not covered under the scheme. They are excluded, but for good reason. They are public health programs that have vertical funding, another source of funding. So at the inception of the scheme, the designers thought it wise to exclude that and keep them as they were, funded by those vertical programs. And the NHIS cannot double fund, and so those were made part of our exclusion list. I think the next slide throws some light on that. So these free public health programs are not covered under the scheme because they have their own source of funding, as I touched on. Okay, next slide, please. In operationalizing the NHIS Benefit Package, because of the unique design where we don't explicitly state what is covered, there was a need to design tools or documents to administer the benefit package. And we do that using the merchants list and tariffs, and then the service list and service tariffs. The service list, especially the details in Annex C. And that's where I'm looking forward to us focusing on, because that's where most of the questions we receive come from. Next, please. So let's talk a bit on the NHIS merchants list and tariffs. Okay. Act 852, what does the act that sets us up, what does it say about the NHIS merchants list? So Act 852 in section 33, subsections 1 and 4 states, and I would like to quote, that the authority shall, in collaboration with healthcare providers and with the approval of the minister, develop a national health insurance scheme medicines list and medicines tariff that is derived from the essential medicines list approved by the minister. Now, each medicine on the health insurance medicines list shall be referred to by the generic name of the medicine unless it is necessary to use the brand name of the medicine. So for those of us who are very familiar with the medicines list, some of the things that we insist on, it's actually carved in the law. The generic listing, the fact that we do a list together with the stakeholders with the approval of the minister, it's all stated in black and white in Act 852. Next. So the typical NHIS medicines list, this is what you'd see. It has a number of columns. There's always a code, a unique code for each medication. Anytime we add a new one, there's a new code that is developed for it. And there's a format for doing so. Then you have the description of the medicines, which is the generic name. The dosage form is stated and the strength is stated. If the medication or the formulation that is on it has a number of strengths and dosage forms, they are all stated individually as line items, separated. Then you'd have the unit of pricing. The unit of pricing is the basis of the price that is quoted. So you can have tablet or capsule or blister pack of 10 or a syringe, and that is how it will be priced. If it is a blister pack of 10, that is the price that will be quoted, and the patient will be given those 10 tablets and would reimburse. If the unit of pricing says one course, then the full course of treatment will be reimbursed at the corresponding price. If it says one tablet, then one tablet goes at the stated price. And if you give more than one, that is multiples, 20 or so, you have to do the multiplication and put in a claim to NHIS for reimbursement. The last column is the level of prescribing. So the lowest level of healthcare delivery at which a specific medicine can be prescribed. The levels of prescribing are taken from the essential medicines list of the Ministry of Health. They are developed by the Ministry of Health, and NHIS does the implementation of that policy to guide our reimbursement process. Okay. Yes, next, please. So the NHIS medicines list sees changes periodically. The Act in subsection 2 and 3 of section 33 says that we shall review the National Health Insurance Medicines List and Medicines Tariff each year in consultation with the healthcare providers and with the approval of the minister. And that the review of the Health Insurance Medicines List and National Health Insurance Scheme Medicines Tariff may involve the addition or deletion of medicines, classification and grouping of medicines, and a review of medicine prices. So we try and do this as the law has said, and a number of you may have participated in some of our reviews, either by giving us data or by participating in the stakeholder engagements that shows as the results of the pricing surveys. Next. So over the past 13 years, we've done about 10 reviews. These are the years in which we've had new medicines lists. And if there are providers in this meeting, if you are currently using a medicines list and it is not the March 2021 medicines list, then you are not using the most current one. So the one in operation now was implemented in March of this year. I hope we are all using the correct medicines list at the moment. Next. So why do we do reviews? Why have we done so many reviews since the inception of the scheme? The rationale is that we need to conform to current recommended treatment guidelines. And we need to conform to economic conditions. Prices change, things happen. And so when we do a review, we have the opportunity to add or delete classes of medicines and also to change prices as stated on the list to conform to what's going on in the country. Inclusions or exclusions of the medicine formulations is based on evaluations of evidence of efficacy, safety, and cost effectiveness. We may add or remove because we have cause to believe that maybe a group of a therapeutic class, one of them is not needed anymore, or the two that are there are able to take care of the conditions okay without necessarily having a third in that therapeutic class. So all these considerations are taken into account when the decisions by experts, clinical experts are being done to constitute the medicines list. Next. What's the medicines list review process? It's not a mysterious thing that is done under the cover of darkness in some way. We usually start with a price setting. Various price setting mechanisms are used now by the scheme. We have medicine price surveys. We used to do that for almost everything on the medicines list, but a lot of things are changing now. Now we use a lot more of negotiations directly with suppliers, especially those that are on patent protection, or there's just one supplier for that medication. It's very easy to negotiate good prices, price rebates, considering the number of medicines that we would be reimbursing for. And a lot of reference pricing too comes to play, especially when you are dealing with orphan medications that usually don't come into the country. And so the pricing is a bit difficult to get. Then in recent times, we've relied a lot on the framework contract data. We're actually enjoying to implement it. The Ministry of Health has been doing framework contracting with the number of medications. It's about 60 plus medicines now. So the medicines prices as they get from the framework contracts are communicated to the NHIS. And so for those medicines, usually they're high volume, high value cost drivers of the scheme. We quote the framework contract prices for those to reimburse. After these price setting mechanisms, there's a number of analysis, price data analysis, inclusion, deletion requests you'd have to collate and weigh them. Then the cost effectiveness analysis is also done in-house. Then the data is shown to all stakeholders for inputs. Some of the prices may change there. Information may come to our attention as to things that may have changed that we have to take action on. So these things are then submitted to a technical committee where the final list is put together, and any questions that have to be answered is done at this stage. Final lists are then submitted to the executive management of NHIS, goes on to the NHIS board for approval, and then to the Ministry of Health also for approval. And then we get the mandate to implement a reviewed list. So it goes through a process. as transparent as possible with the involvement of all stakeholders and with the final approval of the minister as enjoined by law. Next. I think I've spoken on how the medicines are priced, that we use different price setting methods. And for the pricing surveys, I think I didn't mention the fact that we use the World Health Organization, HAI, methodology in settling on the median price. I spoke on negotiations for price rebates, especially for the medications which are under patent protection. And I've talked on the use of framework contracts. We use the contract price and add the recommended Ministry of Health markup, and that becomes the reimbursement price for those medications. Next, please. So how would a provider implement the medicines list if you become accredited? You'd have to dispense medications that are listed in the list. You dispense the medications that the listed price can cover. And this is based on a confident assumption that all the medicines that the facilities will stock are duly registered. And before a medication is registered, it has been certified as safe and efficacious by the Food and Drugs Authority. So the NHI doesn't go into distribution or supply or dispensing to the patients. That is up to the provider to stock the medications and to dispense to the member based on the prescription that is generated for his or her condition. And you do so within the price that has been stated as a reimbursement price. We are aware that trade-offs may happen for some medications because of the wide range of market prices that sometimes we may get during the survey. A price that you may have may hover around the median value that we have set as a reimbursement price. And we know we have evidence to show that sometimes the stated price may be lower than what you may stock, or in very many circumstances too, it may be higher than what you stock. So sometimes the manager of the facility may have to do these trade-offs. You may lose a pesewa here, but you may gain 2 pesewas there. And that's how a lot of facilities that are thriving and providing services to the scheme have managed to do so to date. The stated price may cover branded medications in some instances, and you can't dispense whatever brand you have, even if it's a patent brand. The only thing is that the name of the medication on the medicines list will be the generic name, and when you are claiming for it, you have to state the generic name. Co-payments from members are not permitted under the scheme under any circumstance. Co-payments from members for medications are not permitted under the scheme under any circumstance. Repeated for emphasis. Okay, so the next one that we want to look at are our service lists and service tariffs. I think the medicines list is a bit easy to use because we reimburse fee for service. The medicines is either there or it's not there, it's stated. The service list, though, is quite voluminous, as in being able to know which exact diagnosis, where to find it, how to claim for it, and so on. So here, I'll introduce you to some of the details in our operation manuals, the tariff operation manuals. Next, please. The NHIS service list and tariffs. There are about 600 diagnostic related groupings that have been customized for the Ghana healthcare system. The DRGs were developed in 2008. Prior to that, services were also reimbursed fee for service. Now they are grouped under 11 major diagnostic categories, or MDCs, or clinical specialties, and they are also reviewed periodically, just as the medicines list is reviewed. Next. And just as there's a mandate for the medicines list, there's also a mandate for reviewing the tariffs. The authority shall review the National Health Insurance Scheme list and service tariffs each year in consultation with the healthcare providers and with the approval of the minister. Now, in reviewing, you may add or delete diagnosis, procedures, examinations, classifications, and groupings, and the prices as well. The review process is very similar to what we went through for the medicines list. It starts with the costing of the health services. Costing data is taken from public, mission, and private facilities. Different levels, different ownership, as stated earlier. Then there is an amount of data analysis, development of the tariff, collation of the inclusion or deletion requests, and of course the cost effectiveness analysis is done. Then it goes through stakeholder engagements, technical committee meetings, and then approvals and implementation happens as well. I mentioned major diagnostic categories, I think about 2 slides ago. So the MDCs are the clinical specialties. We have adult surgery, dental, ear, nose, and throat, medical, obstetrics and gynecology, ophthalmology, orthopedics, outpatient department, reconstructive surgery, pediatrics, and pediatric surgery. So all of these are the major bullets. And under each MDC, you find a number of diagnostic related groupings that put together diagnosis that would utilize similar resources. Now, for all these MDCs, you will find them at different levels, facility. Provider categories and the provider types are defined in the Tariff Operation Manual. So for a specific DRG, you may see 1, 2, 3, means it can be done, that procedure can be done and claimed for only at the tertiary care level, secondary care level, and the primary care level. If you see all 1 to 10, then it means it can be done everywhere. So this is what the provider category and the levels just mean when you see 1, 2, 3 to 10 in your Tariff Operation Manual. How do we do the costing? Just like we do the pricing for the medicine. So we take financial data from the health facilities. Now, costing is based on units of health commodities that are utilized in the provision of care. Now, a procedure that requires 1 catheter, for instance, in costing, we will not factor in the cost of the whole pack because we believe in the efficient use of these resources. If it has been established by the clinical experts that you probably go through about 5 pairs of gloves to do this particular change of dressing, we will not cost a whole box of gloves for that procedure. We would cost the 5. If it has been established that a bottle of reagents for a particular test can be used about 100 times for 100 different tests without compromising the quality of the test result, then the cost of that bottle of reagents would be divided by 100 to get that unit cost. This I cannot overemphasize. I think it brings up a lot of questions as to how the tariff is arrived at. Costing is a whole topic on its own, but I'm trying to say this to make us aware of what we mean by units of health commodities that are used in the provision of a particular procedure. Now, the possibilities of handling complicated cases that may require extra resources at higher levels is factored in. We are aware that a condition that may have been referred to a higher level may result in maybe more bleeding. You need more packs of cotton wool to handle it, and also all these things are taken into consideration when we cost, and that's why you may see price differentials in the final tariff that is arrived at. Overheads for larger facilities are factored also as a cost driver in the definition, in the determination of tariffs for facilities. Next. In costing the services, so we look at total direct care costs and then the indirect and overhead costs. And so for the direct care, we look at consumables, the ward, theater, recovery ward. We look at reagent stains. I've talked about that. We look at consumables also in the theater and the drugs that are used for anesthesia. So for service tariffs, anesthesia drugs are embedded in there. The laboratory investigations are embedded in there. You will not see them as separate line items, especially for facilities that are using the bundled tariffs. The indirect care costs takes care of overheads, your vehicle running, maintenance, utilities, housekeeping, laundry. And then there's also, we have tariffs that have catering costs included in there. You realize that human resource runs across, and I'll explain that in a minute in the next slide. So the tariffs recognize the differentials in government support to providers. It reimburses the full cost of service provision for providers with no government of Ghana support. So for private facilities, you realize that we know that your supports may not include that for capital expenditure, HR, and so on. So we factor that in. However, for Ghana Health Service and tertiary care hospitals, these costs some costs may not be included in the tariff. So all human resource that are on Government of Ghana payroll will not be on it. But the human resource on the IGF will be included in the tariff. Capital and equipment costs are not included in the tariff. For child health facilities, in the same way, all HR that is on GOG will not be on it, but HR on IGF will be included in the tariff. You notice here that we don't have the line item capital and equipment costs because that is included in the tariff. Quasi-government health facilities, I think they mimic the GHS and tertiary care facilities in how the tariffs are arrived at. Next, please. The service tariffs. This, when your tariff documents, after you have been credentialed and you begin service, you'll be given tariffs for your level of provision of services. It's usually in this format. You see a code, you see the core Ghana diagnostic related grouping that has been written out, and then you see a tariff, that's a price. So for adult surgery, for instance, this slide, adult surgery 01A, operations of thyroid and parathyroid gland, you'll be reimbursed an amount of 850 Ghana cedis if that procedure is done at your facility, if these are your tariffs, and so on and so forth. You notice that this only states the DRG. It does not give you details of the diagnosis that the physician made to warrant this procedure. Those details are in Annex C of the Tariff Operation Manual, and in a moment we'll go through that. That is where a lot of the challenge is, because it doesn't, if you don't familiarize yourself with the Annex C, you may think a lot of things are excluded. You may not know how to list your diagnosis with its ICD and so on. So we'll go there in a moment, but this is just to show you that every level and every ownership would have a tariff like this. Your code will be there. You'll be asked to state it in your claim sheet. You state your DRG and you'll be claiming for this tariff amount that is specified in your tariff document. Next, please. So we have this for all the MDCs. The previous slide was for adult surgery. This is a snapshot of what we have for ear, nose, and throat. And this is just a snapshot. This is not all of it. Adult surgery is up to over, I think, 20 or 30 DRGs. Just showed a snapshot to let us know how it is presented. Same for ear, nose, and throat. So if ever you are claiming for ENTH 01A, excision and biopsy of swellings of ear, nose, and throat for a member that is greater or equal to 12 years of age, the tariff that will be reimbursed to you is 411 0.59 Ghana cedis. And so these tariff prices are listed for all the DRGs under ENT, as you can see. Next, please. I think the next one is adult medicine. It's also a snapshot of how the MDC would be. Same goes for obstetrics and gynecology. Sorry. And then pediatrics also. As I said, this is not all of it. These are just snapshots. I believe you have your tariff document. So, and if you don't, this is just to say that this is just up to pediatric 13C. It goes on and on, some more than 30 and 40 DRGs per major diagnostic category. Okay. So the tariff operation manual. In the tariff operation manual, there are a lot of details in it. I think once you are accredited, you are given a copy of the document. We've had 4 major reviews of the tariff operation manual. When I say that, I mean that the whole document has been reviewed about 4 times, but the tariff prices have seen more reviews. The document is such that a lot of detail goes into how the tariffs are developed and all that. So it is not at every review of prices that we review the whole tariff operation manual. But at least we've done 4 of that in 2008, 2012, 2013, and 2015. So the current tariff operation manual is the 2015 version, but the current manual reviewed prices is, I think, 2021. So you should know the difference. We've had 8 individual reviews to the prices, but just 4 for the manual. Next. In the manual, you find a number of annexes. You find Annex A. Annex A would give you the framework of how the whole Ghana diagnostic related grouping concept was developed for Ghana. So it describes how it was developed and the details that goes into it. Annex B shows you the GDRD tables by the major diagnostic category. So in Annex B, you see the code and you see the DRG name and the description. Annex C is where the juice is, and that's where we may spend some time to talk on. That's the code to group tables. That's what's supposed to guide us to determine the disease that is covered at our level of care. It will guide us to see the ICD-10 code and the code DGRG and the diagnosis that we have to put on our claims sheet. And then Annex D shows a number of investigations that were added on, I think, after the 2013 Tariff Operation Manual Review. Annex A. So all the guiding principles of the tariff development process are there. It spells out the minimum healthcare benefits that are covered by the scheme. So for what I went through about what the benefit package covers, you find in Annex A. It will tell you how the benefit package was determined. It will show you the development process. And the services that are not covered by the tariff are also indicated. And then the concept of the gatekeeper principle, which we go by, is explained into detail. And the fact that if you go out of the gatekeeper principle, you may not get your reimbursement and so on and so forth. And then the goal and the structure of the DGRD tariff is also explained. I think this document is given to all accredited providers. But from experience, I noticed that most of the time it finds itself in the claims reimbursement office. It doesn't really go down to the practitioners to read and familiarize themselves and understand what it is all about and what is expected of them. And because the reimbursed claims office usually may have a turnover of staff who come and go doing their service and all, that document is never really thoroughly understood. But trust me, if after this training you take the time and pick it up and read You understand how this whole DRG thing came up, how it is costed. And it will even help you to set up your systems in line with some of the requirements to reduce maybe all the deductions, unfortunately, that may happen when some of the guidelines are not followed appropriately. Annex B, as I said, shows the tables by MDC, just the code and the name of the DRG. And Annex C is the code to group tables. Next, please. So for a typical code to group table for adult surgery 01, you recall that in the previous slide in the tariffs, it only showed operations of thyroid and parathyroid glands, and it showed you the amounts that will be reimbursed for. But in Annex C, it tells you that a physician may make a diagnosis of a simple goiter or a toxic goiter or thyroid toxicosis with toxic multinodular goiter, thyroid tumors, parathyroid adenoma, or a benign neoplasm of thyroid gland. All these diagnoses may warrant a procedure of an operation of a thyroid and parathyroid gland. And for that, we would reimburse at that aforementioned price. This makes it clearer, and I know a lot of practitioners they get comfortable when they see this detail. And this is the details that we want you to be familiar with, so that if something presents at the facility, there will be no question as to whether it is covered or not covered. If it's a surgery for lung or bronchus lesions, these are the diagnoses that may warrant that procedure. Next, please. Adult surgery goes on, I told you, it goes on beyond 30 DRGs. I've shown adult surgery 29, 30, and 31 here as well. You may have a craniotomy for these diagnoses, either a fracture of skull and facial bones. The detail here is what usually may lead to a member being turned away, saying this is not covered, you'd have to reimburse for. So please, let's take a moment to go through the ICD-10 codes and the diagnoses that are in Annex C of the Tariff Operation Manual. I'm sure you may be seeing things that you never thought were on the benefit package of the National Health Insurance Scheme. The last column, the level of healthcare, shows us we see 1 and 2. And if you were with me previously, you notice that I defined what these numbers are. 1 was for tertiary care facilities, 2 was for secondary facilities. So we know that for adult surgery 29, craniotomy, you can do this procedure and request for reimbursement at level 1 and 2, tertiary, secondary. And these were all put together by experts, not the NHIS, determined by experts that this procedure can be safely done at these levels. So please, let's pay attention to this as well for the provision of quality and safe health services. Next, please. This is for dental, Annex C for the dental DRGs. For Dent 11, the surgical excision of intraoral lesions would be reimbursed for these diagnoses. So on and so forth for all the DRGs that have been listed. For Dent 16, for instance, if you are addressing an open facial wound, these are the diagnoses that may warrant that procedure. It could be an open wound of unspecified body region or an open wound of other parts of the head. And you can use Dent 16 to claim for reimbursement. Next. The next MDC is, I think, medical. So under medical, you see medical 11, Medi 11, paralytic conditions. These are just snapshots, and I didn't choose in any particular order. I just wanted to give us an idea of the detail that you find in Annex C. So for paralytic conditions, those are the conditions that you may be reimbursing for. Or if it's seizure disorders, the diagnosis may be uncontrolled status epilepticus, dissociative convulsions, epilepsy, status epilepticus, convulsions that is not specified, classified elsewhere, and then any other cause of convulsion. All these have ICD-10 codes specified and developed by the WHO. So they are in there for a reason. The physician will know when to use which diagnosis. But for all these groupings, they fall under that diagnostic related grouping, MEDI12 seizure disorders. The next MDC for Annex C that I want to speak on is obstetrics and gynecology. So in ONG, also a number of DRGs listed there. Let me choose one to speak on. So if you have instrumental delivery, OBGY 29, it may be for an ICD-10 026.9, medical disorders in pregnancy or labor and delivery that is complicated by fetal stress or intrauterine fetal death. For all these conditions, you may need to do an instrumental or vacuum forceps delivery. And so you use OBGY 29 to claim for. If you are claiming for OBGY 26, a hysterectomy, then it means that the listed conditions there, excessive and frequent menstruation with regular cycle, or excessive and frequent menstruation with irregular cycle, abnormal uterine and vaginal bleeding, or polyps, may have been the reason or the diagnosis for which reason you did that procedure, OBGY 26. So you put in a claim for that for payment. Next is pediatrics. So for the children in the pediatric major diagnostic category, P26, if you have diseases of skin or subcutaneous tissues for less than 12-year-olds, it could have been a result of severe eczema, Stevens-Johnson syndrome, or other allergic skin conditions or burns, and for which reason you use this DRG to claim for. Diseases of skin or subcutaneous tissue, if you are only using the tariff document, it's a bit vague. You may not know what exactly to go, but then this, the Annex C will give you the details that are in there. Obstructive airway disease, what is in there? Asthma, bronchitis, simple and mucopurulence, chronic bronchitis, and so on and so forth. So, well, maybe I'm belaboring the point, but I find Annex C to be the most interesting annex of all in the tariff operation manual, and I hope you do too. The next one is reconstructive surgery. So in reconstructive surgery, these are the details of diagnosis or indications for the procedure that you see in your tariff document. A lot of them that we get queries on whether it is covered under the scheme or not. Cleft lip, cleft palate, and so on would require some reconstructive repair. Shaving and skin grafting can be done for burns, traumatic wounds, chronic ulcer, and then burns and injuries if you need to do an excisional debridement and dressing, and so on and so forth. So reconstructive surgery is a major diagnostic category in our tariff operations manual, and it is covered under the National Health Insurance Scheme. I think that was the last slide on the details that I wanted to show, the examples that I wanted to show. But in Annex D, you also see some investigations that were included in 2012 after we reviewed the manual. And this was based on feedback that we had received from the facilities as to some of the laboratory investigations that were not in the former tariff operation manual. So this is just a snapshot of some of the things that are there. Laboratory reimbursements and query issues are up there on the list as to what we cover and we don't cover. In the tariff operation manual, there is no, it's very clear as to what we do. It's not just HB or full blood counts. The detail is all there, platelet counts and so on. And it will be worth it for you all to go through the documents when you have it. Okay, so we've gone through the details of a benefit package, try to make it clearer as to the detail of what is covered. But of course, there are over 600 diagnostic related groupings, so we couldn't have gone through all of them. But I think that in choosing the examples I showed, you've seen the detail as to the individual diagnosis and things that the NHIS does cover. But we can go through in our own time as to the rest of the things that were not shown. We've looked at the medicines list as well. Finally, I want us to take a look at a few considerations as stakeholders of the health insurance scheme. A lot of requests come in for expansion of the benefit package to include a condition here or there. And I want us all to look at the slide critically to understand the position of the scheme. And because we are all stakeholders, if it thrives, it's for our benefit. If it goes down, God forbid, unfortunately, we would all suffer the financial implications. So for the purposes of keeping the scheme sustainable, in considering expansions or inclusions to the benefit package, these are some of the things that the scheme, and I want all of us also to think on, that there are finite and limited resources. And definitely there needs to be some prioritization. That expanding coverage is not necessarily synonymous with quality and access. We may actually put something on the benefit package, or we may have something on the benefit package at present, but we may not be covering it because of access. Our members may not be getting access to it, or we may be getting access, but not at the quality that our mission statement even goes to say, that we want to make the services of a certain quality to our members. Then, of course, rapidly changing demographics and health needs is changing our needs, what we need to see on the benefit package. So we need to think on that, and it may explain some of the changes that we may see in future. Competing needs, I think I've talked on that when you relate it to the finite and limited resources, that you may always have to do some trade-offs and when you are considering adding or removing some benefits. But that said, we continue to have a lot of advocacy for increased coverage from certain specific patient groups and civil society who are the voice of the people. And we do listen to that and subject it to our own in-house analysis to see how best we can serve the nation. And of course, in all of this, sometimes there's some political pressure and the bypassing of all the process guidelines that we've put in because of some expediency, emergency to cover something for members of the scheme. I think we are almost at the end of the presentation. The last slide may have brought up a feeling of maybe we have some challenges in adding or excluding, but there are some opportunities that have opened up to the scheme, that increasingly we are using a lot of evidence to support our decisions on what we add to the benefit package and what we remove from the benefit package. We have an actuarial model in-house, and we use that to project and see how the scheme will remain sustainable if we add on more benefits. And of course, the outcome of that is submitted to the board for the final decision to be made, because we need to keep the scheme sustainable for us and for generations yet unborn. The use of health technology assessment is coming up. The Ministry of Health has set up an HTA body that is to assess some of these requests for inclusions, disease conditions or medications or new technologies or vaccines that need to come in will be subjected to these technology assessment processes to justify its inclusion, so that we know the cost implications and know that the scheme can adequately and comfortably cover it for all members. All of these is based on the fact that evidence-based systematic prioritization of health needs is high on the agenda, and that's the movement now and where we are moving towards. And we crave your indulgence to understand these things when it comes to reviewing the benefits that we all enjoy as a nation, as members of the scheme. In conclusion, I just want to say that I hope that my presentation has shown that the benefit package is very comprehensive and generous as it stands. Providers need to be adept, however, with how to locate and claim for specific DRGs and medications. The details of the services that are covered, you would find listed in Annex C of the Tariff Operation Manual. The policy of no co-payments, it underpins the integrity of the scheme, and it must be adhered to. If there's any question as to what is covered, you can always reach out and find out if you are not finding it in the Annex C of the Tariff Operation Manual. But from the way the scheme was designed, aside those that were listed in the exclusion list, I think those are the disease conditions that are prevalent and occur at our facilities. The majority of them are covered. Additions to the benefit package, we must not do it and compromise the scheme's sustainability. It should be done with care and with the longevity of the scheme in mind. Thank you very much for your attention. I hope that some light has come to us all as to what is covered in the benefit package of the National Health Insurance Scheme. Thank you for your attention. We'll take comments and questions afterwards.
Thank you, Ruby. So now the floor is open for questions, for clarification, and comments if necessary. I hope you know how to raise your hand. If you go to the top of your screen, you see some icons there. You have something that looks like two people. Next to it, you have something that looks like something that people are writing. That is a chat box. Then you see a hand. When you click on that one, you see different kinds of hand. You can raise your hand for you to be called to ask your question. It looks like there's one hand already somewhere. Who is this? Oh, it's gone. Okay. Right. So we are open for questions, for clarification. Yes, Frederica.
Thank you, Ruby, for the very insightful presentation. I just wanted to find out from this presentation if you are saying that no co-payment is not allowed. However, we all know that service provision keeps evolving, and providers are now being asked, or the service is allowing task shifting. And so there are things previously that nurses were doing that were not doing that they are doing now. Midwives were not doing certain things. They are trained and allowed to do certain things now. And even for the fact that policies have been revised and skills have been upgraded, yet in NHIS service package, those things are not allowed. How do we reconcile that in order to provide quality service to our clients? Thank you.
Thank you, Frederica. I think that in as much as things are changing, we also work in a policy environment. So what the NHIS says is, if a facility, for instance, is upgrading its services or has someone who has some skill, it has to go through the accreditation process. The facility must be accredited to provide those services. Then reimbursements will be in line because the things have been designed in such a way that it's linked. If the major overriding policy is not allowing us to shift it, it is difficult for us as we stand as an insurance institution to shift it in-house here. It must come from, sorry.
I don't think you get my point. My point is, let's say a maternity home. A maternity home is now equipped, skilled to do scanning. A maternity home is now equipped, skilled to do vacuum delivery. However, your service package does not allow the maternity home to do that. However, when you take the policy of Ghana Health, the reproductive and health policy that we are all using, it allows the midwife or the maternity home to do that. So it's a bit confusing.
Okay, Frederick, I think we get your point. This actually speaks to the challenge that we have within the health sector, where the policymakers do not seem to work with all stakeholders when they are taking certain decisions. When Ruby started the presentation, I'm sure you saw a slide that showed the NHIS architecture indicating the major stakeholders. On that slide, you saw that the ministry is in charge of all policy directions. And then we have the agencies that work on, I hope, yeah, you are trying to show that this thing, right? Yeah, the ministry is in charge of policy and regulation. If an agency under the ministry decides to change the way they work without involving the other agencies, we may not be aware of whatever tax shifting that they are bringing in. We need to be involved so that we get to know that, oh, these services that were initially not provided at these levels are now being permitted. Because normally they even start with the pilot. If we get to be involved in the pilot, when it comes to implementation stage, we would have factored it in our activities. If we don't get to know what is being done, then NHIA cannot take responsibility for such a thing. So when you get to see that some deductions are being made right from the beginning, which may not be the fault of the facility, we need to be alerted so that we can ask the ministry to clarify what is happening. Then we factor it in our programs. I don't know if that explains it for you.
Yes, it does.
Okay, thank you. But you see, when you get to know some of these things and it is affecting your members, immediately we need to be informed so that we can find out what is happening. Because one other thing too is that we cannot just allow anybody and anything at all to change just because they want to change it. For example, when it comes to the levels of prescribing, we keep getting a lot of complaints from physician assistants and other providers. Whenever we ask them to channel their concerns through the Ghana Health Service to the ministry for them to work on it, because we don't determine the levels. The moment we tell them, they don't do it, but rather they try to find a way to charge the patients. I personally have had occasion to ask, at least on 3 occasions at the ministry, why do they allow people to charge patients for medicines that are not supposed to be prescribed at those levels? I have not had a satisfactory answer. All they tell you, we are monitoring. But if you cannot punish people for doing the wrong thing, then you cannot enforce your rules. Meanwhile, they tell me, and I have observed the fact that medicines that are not supposed to prescribe at certain levels, if you do it and there is an adverse effect, people may have consequences that may not be reversed. I am a living example. I took a medication that honestly, if I had not been rushed to Legon Hospital, I might have been dead by now. So people need to try to understand from our perspective, we don't determine the policy. And when a new policy comes in, we need to know about it before we can factor it in our operations. So Frederica, if you are convinced, then I'll move on to Matthias. So Frederica, if you are finished, then you can drop your hand. Then Matthias comes in.
Please, thank you for the opportunity. My question has to do with the same situation, no co-payment.
Yeah.
With regards to laboratory tests and then medicines.
Yeah.
Provided you went to the market and then you got a medicine at a particular price which is higher than the national health insurance quoted price.
Yeah.
But that particular drug is covered by the insurance, what do you have to do in that situation? Madam made mention that you lose half somewhere and gain half somewhere. The somewhere is what I want to understand.
Okay. Ruby, will you take that or you want me to come in?
It's okay, Doc. You can take it.
You see, Matthias,
Say,
with our pricing method, we use the regulatory recommendation, which asks that we select, when we do the market survey, we select the median price. And as we expect that the prices will hover around the median. So your procurement processes may determine whether the price that you get it is less than or equal to our price or higher than that. But what are the analysis that has been done in about 90% of our medicines, most providers get their medications below the NHIS price, and then when they even add the markup, our prices still are higher. But in some few cases, you get them at prices that may be higher than what the NHIS is providing. That is the median price. That is what he was referring to as that, oh, you may lose a few pesos here, but you gain in most of the cases. But with that also, you need to look at your procurement processes. Look, so we are related to a lot of pharmaceutical companies that are into the wholesales and other things. We get to see some of the procurement practices that are going on. So we all need to look at that and see where we are procuring from and what are our procurement agents doing there, which is causing us not to get the medicines at prices that can fit the NHIS prices. But we don't encourage that you take the money from the patient, because you don't have a contract between you and the patient. Your contract is with NHIS. If the prices you are getting seems to be higher, we need to be informed so that we can all go into it and see whether it is genuine. You are genuinely not getting the medicines at any price apart from what you are getting it from. And with that, I want to tie in with the issue of framework contract. Well, majority of the medications that we have on our list are on the frequently prescribed medicines are on the framework contract. Some facilities, especially the private providers, claim that they are not able to source from the regional medical stores. But per the policy, all providers within the country are supposed to source from the medical stores. Even community practice pharmacists are allowed to source from the regional medical stores. So if you have any challenge in sourcing from those ones, let us know. So we also inform the ministry for them to find out what is happening, and then we all streamline it.
Okay, thank you, sir.
If you charge the patient, that is you see, when people are ill, that is when they are most vulnerable. So people take advantage and charge them. And then when you do that, you are sabotaging the NHIS program.
Okay.
Matthias, if you then I move on to Emmanuel Afifa.
Okay.
Afifa, have you dropped your hand? Yeah. Emmanuel Afifa. Please, Emmanuel, you have raised your hand. If you can unmute your mic and speak.
Hello.
Yes, we can hear you.
Okay. Okay. So thank you very much, Madam Ruby, for that amazing presentation. I've got two concerns. And now my concern has to do with when claims.
When claims.
Hello, Emmanuel.
Are made, i.e.,
Emmanuel, we
the
lost you,
NHIS
so you
tariffs.
can.
Hello.
Yeah, we didn't hear you. Yeah, we can hear you now.
Okay. So, well, so my concern had to do with the claims veterans reports. We've had instances where claims are submitted in month one, and then the veteran report for these claims are actually sent to the facilities 5-6 months after these claims have been submitted. Now, when there are any anomalies, because the veteran report comes 5 months after these claims have been submitted, it gives the facility little time to make corrections. Now, when this continues, then what it means is if there is any anomaly in the submission of these claims, then the health facilities will then have to, suffer for 5 additional months because the veterinary report came down 5 months after these claims were submitted. If the authority could have a proper look at that, at least to reduce the rate at which deductions are made. Now, the other concern has to do with bringing in technology to ensure and then to reduce deductions that are allocated to health facilities. For some few years back, there was this rollout of a claimant software. Now, on the part of service providers, we all allude to the fact that the human error component is a very, very key component that cannot be omitted. That is where technology comes in now. Now, my concern actually has to do with comes in a form of an appeal. If the authority could kindly step up its enrollment in the claimant software, because there are facilities who have actually applied for credentials for over 2 years. That is the claimant software credentials for over 2 years, and no feedback has been gotten since. So if the authority could respectfully have a look at it to ensure proper reduction in the claims deduction for healthcare providers. Thank you very much.
Thank you very much, Emmanuel. But when we were doing the introduction, when you got to your turn, we didn't hear your voice. Can we know where you are coming from? And then
Okay,
also, if you
so
can let me know where you submit your claims.
Okay, so my name is Emmanuel Frifa. I'm the claims manager for St. John of God Hospital in the Western North region, Sefioso, and the chat. Now we submit St. John of God Hospital.
St. John of God
Hospital. Yes,
okay.
Seshi Asafo.
Okay.
Now we submit our claims to the CPC Center, Kumasi.
Okay. All right. Thank you very much. And sorry for the delay in the getting the vetting report. We will pass on the message and find out what is happening and then what can be done. We hope it will improve quickly so that you get to learn from that. But hopefully you get your vetting report before the payment for that particular month is made. So going forward, we pray that it will be more frequent so that you can learn from it and then avoid the mistakes. And then also we will take up the issue of the claim it rollout and then report on it so that whatever can be done will be done. We actually don't know much about the rollout of the claim it, and then we don't know what may be holding it. So we need to get back to those involved to understand what is happening and make suggestions as we have requested. C, that is all I can see. C. Oh, you have dropped the hand? Okay, Mohammed.
Morning.
Yeah, good morning.
Yes, I'm from St. Joseph Health Center, Calva.
Okay.
Yes, the issue I have for you is that we are worried about this usual thing that NHI normally do. I don't know, it seems even other facilities encounter the same problem. The issue is that, let's say I submit January, February, March claims. Let's say up to May. NHI is now coming to pay, and they will come and start from June. You see, so the next time they are paying, they will go and pay, let's say, August. Then they will be jumping
Mohammed,
like that till the year ends. Please let me learn it.
No, please, please.
Yes.
Please. You see, we are doing a training on the benefit package. Yeah, we are not saying your concern on claims is not important, but I think this is not the forum for it. So if we can stick to, maybe others may have questions that they need clarification on the presentation that we have done. When we are done, because of what we are doing, I'll give a few minutes for any other business. And then maybe take the concerns and then present it to the appropriate units, please.
Okay.
So if you have a question on the benefit package, then we can go ahead. If not, then you can drop your hand and we'll go to the next person.
Thank you very much. Thank you very much. Yeah.
Okay. Right. Any other person with a question on our benefit package? Any question on the benefit package presentation?
Doc, please, whilst the questions are coming in, I think for registration purposes, if participants can, Doris has sent a message, if participants can kindly share full name and institution for registration purposes. Thank you.
In the chat,
box, please.
Yeah, please help us with that so that we know those who participated. Emmanuel, I've seen your hand again.
Okay, so I'm back one more time. Now, my final concern has to do with in our practice as healthcare providers. One thing we've noticed is there is a gap. There is a gap between what the medical doctors think, what the physician assistants think, and then what the authority also feels should be allocated or allotted to a patient. I'm talking in regards to diagnosis. There has been instances on the ground where the claims office, in fact, walks back to the doctor's consulting room and then tells the doctor that, doctor, diagnosis A you actually gave to the NHIS patient cannot be found in the claims manual. Now, we sometimes have deliberations with them, then at times they are able to more like choose a related diagnosis that can be found in the manual. There are instances where some doctors also I feel diagnosis A is what is wrong with the patient, not what the authority is saying as diagnosis B. When it comes to instances like this, we want to maximize practice. When it comes to instances like this, how do we address it? Now, we feel...
Emmanuel, are you done?
From the topic. No, sir. No, sir. Yeah. Please, I want to answer. Okay, so we feel if there could be a broader spectrum between the MDC, Ghana Health Service, and then the authority, in fact, for prescribers to be thoroughly taken through, in fact, what they should be doing, because the confusion at the ground is very, very serious. I'm done.
Yeah, Iman, I think you have spoken to the need for this training. That was why, you see, we didn't decide who should even attend. We were hoping that the practitioners themselves, like you, as you were saying, the doctors, the physician assistants, the nurses, the midwives, would even take advantage. But they most often complain that what they are doing is not covered by the NHIS. But as you can see from the tables that we have shown you, when it comes to, when you take the DRG, we have a list of diagnoses that go under them, the ICD-10s. You see, per the NHIS regulation, our benefit package is not listed on its own, but rather what is excluded is what is listed. And when you go through the exclusion list, it is very, very minimal. So it tells you that whatever is not clearly listed as excluded is actually covered by the NHIS. So how do you then practicalize that one so that people will get to know what exactly is covered? That is what the Annex A of our Tariff Operations Manual is doing for us. So we try to organize this training so that we can expose the practitioners to it, and we hope that those who did not join today will join the subsequent ones. I think next week one is likely not to come on because we have a class of program, but we may try and see if we can shift it to another date. So we will send that notification out after we have actually discussed what to be done and sought permission before agreeing on a date. So we hope that you can send the message to your doctors and nurses within your organization that they stand to rather benefit from this training that we are organizing, so that they will be on the same page with all of us. Ruby, I think I've seen your hand, so if you want to add something.
Yes, Doc. Not to add, but to ask Emmanuel if he can throw some light. I wanted to find out, is it the case that practitioners cannot find a diagnosis they want to make after even going through this Annex A that we've talked about? Like, it's not listed there at all, or maybe they don't know how to find it. But if it's not there, then the stakeholder engagement comes in. We would like to know what it is to inform the experts and see how we can deal with. So, Emmanuel, if you can respond, so I know.
Right. So the concern clearly has to do with just what Madam Ruby re-echoed. We go through the diagnosis list, and then this particular diagnosis prescribers feel is wrong with the patient cannot be found in the diagnosis list.
Okay. Then, as Ruby indicated, we will be glad to receive some of these feedback. Sure. Instead of forcing it somewhere, because if you didn't find it in the table to the C table, and you did not also find it on the exclusion list, which means if it is not on the exclusion list, it means that it's covered. Then we need to get those kind of diagnoses. Then we try to update where necessary. But if you don't hear about it and then you only charge the patient, and that is, it all goes against the whole program that the nation is running.
Doc, okay. If I may also add, there was some deliberation in time past about some of these ICD-10 codes. You realize that for every procedure, there's always this one ICD that will probably say maybe dressing or debridement of an unspecified region or body area. I think some of those things were put in to cater for some of the gray areas that a physician may not. But we want to know the specifics Emmanuel is saying. But I'm sure that if we have opportunities for further training and going into these ICD-10s, then we will know how to pinpoint or find the appropriate ICD when it is not there how we want it to be there. I hope this would help in the time being, Emmanuel.
Very useful, because when we get to know, then we know whether it is actually hidden somewhere that they didn't find or not. Then we can point them to that. So Ima, help us spread the news so that whatever you are experiencing that is outside what we are doing, let us know so that we can also factor it and improve on our functions. I don't know, Comfort and Frederica, I don't know who came first, but Comfort, alphabetically, let me go for Comfort then.
Hello, good morning, Doc.
Good morning.
Yeah, I'm Isaac. I'm with Madam Comfort from SDA Valley View Hospital.
SDA?
Valley View Hospital, OEB.
Okay.
Yeah, please, thanks for the presentation. How do we get a copy of the Annex C? Sorry, we came in late.
Does it mean you don't have a copy of the manual at all?
We have the manual, but it's very old. So we want to know whether the updated one is available for.
Old, which version do you have then? Which year is written on it?
2012.
Okay, so you need a 2015. Go,
Yes,
you see, normally we like to follow the communication channels so that people who are closer to you can serve you better. I think
okay.
you may need to go to the regional office if necessary.
Okay.
Then, if they don't have copies, they will know how to direct you to get a copy.
Oh, okay. All right. Thank you very much.
Thank you too. Frederica.
Thank you very much once again. I just wanted to add, mine is a suggestion.
Okay.
For the treatment of the cancers, the cervical and the breast cancers, you know, most of these diagnoses are made through mass screening programs.
Sure.
Unfortunately, these mass screening programs are not covered. And so sometimes in the facilities will have to look for their own funding to do these mass screening programs to identify these people who actually would be diagnosed for treatment. I don't know if it is possible, but I would also want to suggest that the National Health Insurance includes preventive care, because sometimes these preventive care are usually much more cost effective than when we are doing the more curative aspects. So my suggestion is also to include these screening programs, the breast cancer screening, cervical cancer screening in the benefits package.
Yeah, thank you very much for the suggestion, Frederica. I think discussions are ongoing, but you know, the preventives were not given to the NHI because we had the public health units within the Ghana Health Service and the ministry who were handling them. But there are discussions ongoing to see what to be done going forward. So we will take your suggestion on board. It's because it's better to prevent it than wait till the people get the condition which costs you so much. But we need to also, if you are going to go into prevention, you need to know what constitutes that prevention aspect that you are going to do and who should get it and how often. All those discussions are ongoing, and at the appropriate time, I'm sure the ministry will make an announcement. But it's a good suggestion. Thank you very much. Any other hand somewhere? I don't seem to see any hand. But there is indication that someone has raised the hand. Yeah, Alex. Hello, Alex.
Yeah, good morning, sir.
Good morning. And when we were doing the
yes,
introduction,
thank you very much. I just, I have a comment.
Who is this Alex? Please let us know who you are and then continue.
Okay, Alex Mason from the Child Secretariat.
Okay, let's hear you.
Yes, I introduced myself as Alex Mason, Child Secretariat, Accra.
Okay. Please, let's hear your question or comment. Is it only me who can't hear him, or you can all hear him?
First of all, those who want to take part in this meeting, are they prescribers or facility managers or owners?
Yeah, Alex, I think any provider who can benefit from the present and who can
Hello,
benefit.
can you hear me?
Yeah, I heard you. Alex, can you hear me? Hello, Alex, can you hear me? Hello, Alex. Okay. For the benefit,
Hello.
yes, Alex, I can hear you. Can you hear me?
Yes, I can. Yeah,
Yeah,
so my,
I understood
my
your question. You
comment,
wanted to know which cadres can attend.
yes, for the benefit of getting the best out of the meeting, we should target. If there are prescribers we want to meet, we should know. If there are managers, so that as the questions were coming, people were bringing issues from all other angles. And then the second point is that we used to have a lot of such stakeholder engagements, and that was helpful. You see, people are asking questions from other units outside your remit. So if we can look at how we can revisit some of these things so that we don't pile up issues for people to make mistakes and cause financial loss only after a clinical audit uh, years after the effect. So those are my comments for now. Thank you very much.
Yeah, thank you for the suggestion. I'm sure we will capture your suggestion as to other units having regular engagements in our report. But concerning who we are targeting, I think we are targeting all categories of providers, prescribers, dispensers, and if the facilities think that those who work on their claims will benefit from this training for understanding it, they can also join. But we don't know what the capacity that the Microsoft team can take at a time. So when you are trying to join and it is full, then you try to join the next one. So we don't want people to be repeating themselves, so that others can also have opportunity to listen to the content and then ask questions as much as possible. And then also, after you have joined this, if you have other suggestions, please don't wait until maybe something like this is organized. Let us hear whatever concerns you have on NHIS. You can write to us. Our doors are open to listen to you, so that you see your question may even prompt us to do something that we might have overlooked. And that is why how come we are stakeholders. And as stakeholders, we need to work together to ensure that the program succeeds. And as I most often say, the NHIS is a national project. All of us have to make sure we work together to make sure it succeeds. For a time may come that I may not be sitting here, but when I'm not here, I will still need the NHIS. So we need to make sure it works, it succeeds, it is sustained, so that we will all benefit from it. So whatever we need to do to help, please don't let us wait until stakeholder meetings are called. Alex, are you okay?
Thank you, sir.
Thank you very much. Moses.
Yeah, good morning.
Good morning. And can you introduce yourself and then tell us where you are joining us from? And
Yeah, I am a prescriber, physician assistant at St. Vincent de Paul Clinic, Drobonso.
okay, thanks for joining us.
Thank you. My question has to do with my facility used to undertake medical outreach programs in our catchment area.
Okay.
We try to let NHIS holders benefit from that package,
Yeah.
but our district manager told us that
the rules guiding the scheme is that it should be location specific. So if we move our service from Drobonso to say Dagomba, which is about 1 kilometer away from the facility, the NHI cannot be applied over there because it should be location specific. So I want to ask, how do NHIS holders benefit from such outreach programs?
Okay, Moses, thank you for this. What I know is that outreaches are allowed, but you need to pre-inform the NHIA with your program of your program for the year of the period that you are going to do it. But you see, as you are saying, is that the community is called what?
The community is called Drobonso.
No, you are in Drobonso, but the community you wanted to do the outreach in.
It's called Dagomba, and it is under us.
Yeah.
It's in our.
Your facility is not at Dagomba, but you want to go there because they are far from you, so that they will benefit from your services. It is allowed, but you need to pre-inform the NHIA with a program for us to know that you will be there within that period that you are telling us. So when a claim comes for services that were provided within that period, we will be aware that such claims were coming. But if we don't get to know anything at all, then you are there, then you see a claim from Dagomba, where we know there is no such facility, they will definitely have to reject that. So please, you have to draw your itinerary, discuss this with the NHIA team for them to know the period that you are going to do the outreach. Then we know that such claims could be coming from those communities. I hope it is clear.
Yes, please. Thank you very much.
Thank you too. Any other question on the benefit package presentation before we make some time for other business, if any? I don't seem to see any hand. Oh, okay, Matthias.
Yes, sir.
Okay.
Please, I want to find out something concerning a suggestion one made earlier on about a diagnosis not found under the Annex C.
Okay.
There is under adult surgery 34, conservative management of surgery.
Okay.
Under that one, there is an inscription that this DRG may also be used for other medical diagnosis as well. Please include diagnosis on the claims form. Yeah. So normally what we do is when there is a diagnosis that is not really in the Annex C, we quote it under this, and then it's being paid for.
It is being paid, right?
Find out. Yeah, I also want to find out about retroviral treatment in case somebody comes on admission with retroviral, like HIV. How is that one captured? Maybe the person has been admitted for HIV.
You know, thank you very much for the suggestion. What you are doing with the conditions that you don't find, but you are able to put them under the adult surgery 34, and then you indicate the conditions. So it is helping us gather the ICD-10s so that we can now, if you check, if you get the tariff operations manual, different versions, you see that there may have been additional DRGs that might have been created.
Yes, please.
From information like that, that help us in creating the DRGs that may not be there, or including the ICD-10s in the relevant DRGs so that people can find them. So please keep doing that for us. And I'm happy you are indicating that you get paid for those ones. So it helps us in making sure we update as much as possible. On the retroviral.
Hello. I'm also unable to do the registration. When I click on the chat, it tells me I'm no longer part of the meeting.
Oh,
Yes, please.
this particular meeting.
Yes, please. When I click on the chat.
I'm surprised because we can hear you, you can hear us.
Yeah.
So then it may have to do with the technology. So we need to investigate this. I think
Okay.
next time we may have to have one of our IT guys to join us so that they can help us as much as possible. So, but thanks for bringing this to our attention. On
But
the
yeah,
issue of
Matthias from, so we register
Hope,
you.
yeah, Hope Christian Hospital, Gomafete.
Hope Hospital.
Okay.
Hope
Is that from what?
Hope Christian Hospital.
Yeah, Gomafete.
Yes, please.
Yeah, on the issue of retroviral treatment, that is not part of the NHIS benefit package. So I think the patient, you need to find out where they are getting their medications from so that you know how to help them as much as possible. We know they get it from Ghana AIDS Commission, but they may have outlets where they collect their treatment from. So whilst they are on admission with any other opportunistic infections which we pay for the retroviral treatment, they need to get it from the right sources.
Okay, but what we normally do here is, in case the person happens to be diagnosed here for the first time, we bill for the retroviral for the admission. But if the person has been referred from another facility, we find out an accompanied diagnosis to use for the person.
But I don't know if you get paid for the retroviral treatment itself.
No,
but,
please. Like in case the person is being served the medication from another facility, but came to our facility on admission.
Yeah.
We use an accompanied diagnosis to bill for the admission instead of the retroviral.
Yes, and that is right, because we pay for all the opportunistic infections.
Yes, please.
So the suggestion I made was for the retroviral treatment itself, because they need to collect it from Ghana AIDS Commission accredited outlets. You got it, and then okay. Frederica, your hand is up.
Yes, thank you once again. I wanted to find out, how often do you refine your actuarial modeling? And then also, if you have a calendar for reviewing this benefit package, at least if you make us aware of that calendar, then if we have issues, we know that there's a certain window that we need to make our issues known so that in the revision it will be captured. So if we can have the calendar of your review, and then if you let us know how often you refine your actuarial modeling.
See, for the actuarial model, we have an actuarial director that actually looks at it almost every day that they come to work. When suggestions are coming, issues are coming from outside, it is referred to them to look at it. Almost every day, there is a actuarial team that looks into the actuarial model. But for major reforms that come up, like when we hear, oh, you need to cover prevention, then you try to ask questions. Then that one, when those suggestions are coming, it is referred to them to do the necessary literature review and then conduct analysis to see how they will impact the NHIS and how best we can take those things on board. For the medicines list, we are under law to do it annually. Every year we review the medicines list. And then, as Ruby took you through, reviewing deals with both the prices and the medication that itself, whether we are to add or we are to remove based on evidence that are available. So our doors are always open for suggestions. So don't think there is a specific window that is open before you can submit suggestions. No. Ruby, do you want to add? I can see your mic on.
No, I think you've got, no, I'm fine. Thank you.
Okay. Frederica, so you are always welcome with suggestions. And that is what we even like, because we don't want people to wait until we call meetings before then they bombard us with, oh, do you know this is happening? Do you know that is happening? That is not helpful.
Okay, thank you.
Yeah, the moment you observe anything that you think can be refined or can be done differently, you need to let us know. And our doors are always open. Any other questions on the benefit package? Okay, I can't see any hand, but because of Mohammed, let me give 5 minutes for, or okay, let's make it 10 minutes for other questions on NHIS that may be beneficial to all of us. So, Mohammed, I know Emmanuel, I know your hand is up, but Mohammed was the one who brought this up. So let me give him the first option.
Very much. Yes, so like I was saying, hello. Hey, am I muted? Hello?
Hello,
yes.
Emmanuel. Emmanuel, I can hear you.
This is Mohammed.
Yeah, Mohammed, go ahead. Mohammed.
So like I was saying, so I submit claims from January to say July. NHIS is going to start paying me, then they go and start from March. The next time they are paying, they go and pay August.
Okay.
And then it runs like that till the year ends. And once the year ends, sometimes they don't go back again. We have a lot of them here. Yes.
Okay, please.
Currently, the NHI has started paying some facilities. In fact, 2021. We are still having claims dated back 2020, 2019, 18. So we don't understand why, at least if we submit January 1st and you are paying, if there are issues with it, maybe we have to be notified. Otherwise, you have to start paying from January. Why do you jump from January, February, then you go and pay March? The next time you are paying, you jump and go and pay July. I mean, it creates serious confusion. And also very important, very important, the narration. Most at times, I don't know, other facilities may bear me out. When payments are done to our bankers, you print your statement and it is salary processing. Salary processing, just like that, from NHIS. You are unable to tell what kind of salary is that. Yes, we know it is claims they have paid. Which month is that? You don't know.
Okay.
So seriously speaking, I know maybe other members on this platform, I think they should be aware of this issue I'm talking about. Thank you very much.
Thank you, Mohammed. And on the last issue that you raised, that one has to do with your bank. It is how your bank has configured their IT system which is causing that problem. Because I've had several issues on this from providers, which I have followed up personally with our finance. I have seen the screen. I've seen the screen that they share when they do the payment. They indicate the month of payment. Okay, for claims. So your banks need to reconfigure their systems so that they can now alert you that this is coming from NHIA for this particular month. So that problem is not coming from NHIA, it is coming from your bank. So have a discussion with your relationship manager at your bank. Then in the issue of your claims not being chronological, there is an email address where you can actually send your concerns to, and it will be addressed. I will look for that email and then share it with I think with the I think it is claims payment something. I will look for that email and share so that you can send your concerns to that email, and I'm sure it will be attended to.
Okay.
Okay,
Yo,
thank you
thank you very
for
much.
your attention.
Yo, yeah.
Yeah, it is claims payment, claims, one letter, so that it is plural, claims.
Claims payment. Okay.
Claims payment, one word, claims payment, one word, at nhia.gov.gh.
.gov.gh.
Yeah, .gov.gh. So claims payment, one word. And then man, you don't forget the S. It is claims payment
Okay. Okay.
at nhia.gov.gh. When you send it
Okay.
there, it will be someone will attend to it and then make sure your issues are resolved. Thank you
Thank
for
you
your
very
attention.
much.
Yes,
You're
Iman.
welcome. Yo.
Okay, so mine has to do come in the form of an appeal. In fact, we are humbly appealing to the authority that given how successful this webinar has gone, we appeal that subsequent ones, in fact, should include all the various departments under the authority, say the finance, climate, credentialing, so that when we meet in one group like this one we've just had, at least issues can then be directed. So if, let's say, this month is earmarked for issues relating to IT or credentialing, we can then prepare adequately and then present our complaints to ensure prompt reactions to our complaints. Thank you very much.
Thank you, Iman. Now, I think that is what is happening. So we are dealing with the benefit package. I'm sure the other directorates will also organize similar training programs for providers. So we will carry that. But I don't think all of us can come together. No, it will be difficult. You see, look at our presentation, how long it took. Yeah. And imagine you are doing something on QA, then you do something on finance, you do something on audit. It may be something. Okay, so I'm sure they will also organize their training programs. So when they advertise it, I hope the facilities will take advantage of it.
Right. Thank you very much.
Thank you too. Any other question for clarification? Isaac.
Hello, thank you, Doc.
Please, Isaac.
Hello, Doc. Thank you very much. After we received a vetted claim, that is SDA Valley View Hospital.
Introduce yourself. Who is this Isaac?
Isaac from SDA Valley View Hospital, OEB.
Oh, okay. Right.
Yeah. We received a vetted claim, and the net amount wasn't paid, but a rather amount which has been deducted again. We wrote to the authority and we followed up, but still we've not heard anything from them after the vetted claim amount.
Okay. Yeah. So when you say you followed up, where did you follow up to?
We followed up to the CCC office at the Jolu and also at Accra with letters.
Okay, Isaac, I don't normally get involved in this, but I will kindly send me the relevant documentation. Send it by email.
Okay.
Then I'll try to understand what is happening. Then go to the wherever you said we went, wherever they need to work on it, so that maybe when we understand it, we will know who can help.
Okay. So we went to the finance office at Accra and they told us the vetted report they also got from where it was vetted from. It looks like the reports were mismatching. What we received and what they also got to pay us were different.
Yeah. This is why I want to understand. I want to see it so we understand it and then know how to advise appropriately.
All right, Doc. I'll do that. We'll send it to you.
Thank you. Who else has the hand up? There seems to be a hand somewhere that I can't see. I can only see Isaac's hand. He has spoken, but it is indicating that there are two people who has raised their hand. So who, yeah, this particular hand is missing. I can't see the hand. So whoever has his or her hand up, please let us hear you. Okay, if there's nobody there, if there's no question, Ruby, do you have any closing remarks?
Just to say thank you for the opportunity and thank you to all who logged on. It's been a good time. I look forward to the other engagements with other service providers. Please spread the word if it's been useful to you so that together we can get as much knowledge on the benefit package and serve our members to the best of our ability. Thank you. Thank you once again.
Thank you very much, Ruby, and thanks for all the participants. As she has said, spread the message for us. Let us also know if anything did not go well. Dr. Dia, your hand is up.
Okay, Dr. Senso, thank you very much. And Ruby, it's been a long time, Ruby.
Yes, Dr. Dia. Thanks for joining in.
Yeah, I've listened to all the conversation and the complaints from our facilities, and we want to thank you very much for your time. It's been quite a long time engaging. I see that this service will be very good to our members if you have time to organize it regularly, maybe every quarter or so. So, Dr. Senso, I'll plead with you if you have time, every quarter or every 6 months, if possible, so that we can sensitize our members to participate. NHIS is the soul and spirit of the services that we deliver. If NHIS is not there, CHAG will be the prime loser because of where we are. And for that matter, if NHIS succeeds, CHAG also succeeds. And we want to thank you for your time in organizing this. Very, very grateful.
Thank you very much, Dr. Dia, for these words. We are grateful. We will make the suggestion to management and see. And to be honest with you, executive management is also keen on organizing this regularly. But as you know, there are other directorates. So we will see how best we can cooperate and then make it a regular feature so that we all get on the same page so that we can serve our members better. Thank you for the kind words.
Very well.
And I've actually indicated your statement. NHIS is the soul and spirit of healthcare service delivery in the country.
Very well. All right. Thank you.
Any other hand? If not, we are gradually bringing our engagement to an end. Thank you to all those who made time to join us. Spread the word for us and have a good day. But if anything went wrong, please let us know about it so that we can improve. Because, oh, there's a last minute hand. Malagai Samuel. Is it Malo or something? So Samuel, please, let's hear you.
Yes, sir. Good morning.
Good
Yes,
morning.
good morning.
Let us know who you are and then what you want us to hear.
Okay, this is Samuel Malugai. I have origin. I'm the NHI focal person.
Okay.
For Ghana Health Service. But I think I joined very late. I didn't see the message early. The meeting link. It didn't come. I didn't see it early, but I would want to know how often and how regular will this particular meeting be scheduled, and then subsequently, if it could also be made known earlier, so that if you could spread the word for those who have time to join as well.
Okay, so Samuel, I think you have another opportunity. Unfortunately, I think it was supposed to be all Tuesdays in September, but this year, but something is happening next Tuesday. So next Tuesday we may not be able to do it, but I need to confer with leadership to be sure if we can either do it the next day or Thursday. Then we shift to the other Tuesdays. So today is 7th, 14th, 21st, and as for 21st and 28th at the moment, yes. Yeah, Ruby. Okay, so it's not. Yeah.
Hello.
So you have someone. You have another opportunity to join us, and we sent this link to leadership. I'm sure they will share it, and then you can participate. Okay,
Okay,
so
and then
all is not
notwithstanding.
lost.
Okay, is there any other materials that you can share with us?
Materials like
Maybe this meeting
presentation
you
that
had
you want
some
us to send to you.
slides. Maybe if you have some slides or some presentation you made, if it can be shared with us.
Let us finish all our training program for the month, and we can share the presentation if necessary. But do you have access to the NHIS Tariff Operations Manual?
No, I don't have it.
Okay, so go to the nearest office and request for the NHIS Tariff Operations Manual. Then they will take you through a process for you to get it, please. Because as the focal
The
person,
tariff operations manual.
Tariff Operations Manual, as a focal person, you need to know it and know the content so that you can help as much as possible.
Okay.
Okay. Dr. Christian, I'm
Yes, thank you very much for the opportunity. I also want to add my voice to the others to thank you very much for a very good presentation and very educative program, and wish that we regularly do this to bring our people up to speed with what is happening. The other thing is to ask whether you have soft copies of the benefit package, and if these could be made available at agency, at least secretariat, so that some of our people could have their issues looked at when we have peculiar, circumstances that are sort of aligned to just certain agencies.
I don't know whether you have stopped. I can't hear you. But if you have finished, the Tariff Operations Manual is available. So I think we need to take steps for you to have a copy. Go to the where are you joining us from?
Well, I'm joining you from my residence.
No, like what facility do you operate from? That's.
I am the president of the Kwesa Government Health Institution.
Oh, okay. Please, kindly drop us your email. Then we will make sure you get it so that you can even share with your members.
All right. Thank you very much. Thank you.
Thanks. Dr. Dia, is that a legacy hand, or that was a term I learned yesterday? Is that a legacy hand or is a new hand?
It's the old hand.
So it is a legacy hand. Sami, is your hand? Also, I'll come to you, but okay, Sami is gone. So also.
Thank you, Doc, and good morning to all the participants. All I want to say is that we want to say a big thank you to yourself and the team for this super enlightening session. I mean, even though we are sitting here in NHIS, every day comes to us as a learning day and a learning curve for us to enhance our knowledge. So we say thank you. On a program like this as well, from where we sit at Corporate Affairs, for us, one of the biggest challenges is this issue of co-payments, unauthorized fees being charged to our members almost entirely up and down the country. And it's a serious issue that confronts us every day. So we would have hoped that on a meeting like this, perhaps you can get commitment from our key stakeholders, being the providers, that they will also ensure that they will do everything in their capacity to eradicate this menace for us. Because as he says, the NHI is just one, and it's a heartbeat of everything in the health sector. So together we have to try and see how best we can minimize, if not eliminate, these unauthorized fees. I know it's a bigger issue, but we should all have the commitment, especially hearing this presentation on what it takes, for medicines list, the tariffs, and so on and so forth. So hopefully next time around we can get a firmer commitment on how we can eradicate co-payments. Thank you very much.
Thank you too for your suggestions. And I'm sure they have heard it, and all of us will work together to ensure that we eliminate the illegal I don't even call it co-payment. I don't call it co-payment because co-payment is what is officially allowed to be.
Oh, it's okay.
What is officially allowed to be taken, but once it is not allowed, I don't see it as co-payment. I see it as illegal payment. So we need to all work together, and I think this is a first step for people to get to understand what is actually covered by the NHIS and what is not covered, and how can they build the NHIS so that they will not take it on the patients who may be vulnerable. And when you are ill, you are so vulnerable that when you are asked to pay, most of you can't ask questions. But we plead with the practitioners that that is not the time to take money from the patient when they have valid NHIS card. And I'm sure they will agree with us that the issue of claims payment, which used to be something that was a problem, is gradually being improved upon, and I'm sure management will improve upon it better so that we will not have any justification to take money from the patient. So thank you for bringing it up, and I'm sure the providers going forward will help us to eliminate the issue of illegal payment. And we are grateful that at least you saw the training to be beneficial to even in-house staff. We promise that when the opportunity presents itself, we'll continue to do it as often as possible. But the intention is to make sure we are all on the same page, and then we don't get to hear issues of illegal payments and this is not covered and the NHI is not working and all that. But we want all of us as Ghanaians to be working together, and then we will all be proud to hold our chest out that as a country we have a system of paying for healthcare that is working for us, so that when I'm on retirement, I can also benefit from it. Thank you. Any other comments before? Because we still have time before 12. If not, if I don't see any other hand, then we would like to thank all of you once again for joining us. Please spread the message for us so that others will also take advantage of this. Those who haven't had copies of the manual, take steps so that you can get the manual, read them, and then review, and then let us know where we need to improve as much as possible. And going forward, as also said, we want to hear that people are not being charged for services that are covered by the NHIS. Thank you very much and have a blessed day. Oh, Samuel has come again. Samuel will close the meeting. Okay, Samuel, let's hear you. Hello, Samuel. Can you hear me, all of you, apart from Samuel, or I'm not being heard at all?
You can be heard.
We can hear you.
Yeah, so Samuel, you raised your hand at the tail end as I was going to just close. Well, it looks like it was a mistake. So thank you very much to all of you. And then we
Can
hope.
this electronic copy be made available for?
Who is speaking?
I think Samuel is now speaking. Probably there was a lag.
Yeah, Samuel, can we hear? Let's hear you then. Well, on the issue of the soft manual, I think what we will do is just like we send the notification to the lead heads of the institution for the provider group, we will send it to them so that they can now share with their members. Then they take responsibility if the members don't have it. So I think that is what we will do. Thank you very much. So we have come to the end of the first day of training on the benefit package. We hope to come your way another day with a different set of people to join us. Bye-bye.
Are we praying?
Did we have it on the program? Did we have a closing prayer on the? Yeah, it was closing remarks. You didn't put a closing prayer there. That's why. So, for those who wanted to see our faces, that's me. Bye-bye. And that's Ruby. I'm sure Ajua is hiding somewhere. Yeah. Habakkuk. Yeah, Doris there. Okay, so bye-bye to all of you. Spread the news for us. And CAF, I have seen that a mail has dropped from Karim, so I'll take a look and then get back to you, Karim. Okay, that is C.
C, please, what's your full name?
Please, your name again, we didn't get it.
Comfort Aho from SDA Bawi.
Okay, SDA Bawi, Comfort something. Yeah. If you can write the full name in the chat box for us, it will be good for us to have it so that we keep the records.
Okay. Okay.
Chief. Yeah, my boss, good morning.
Chief.
How are you, sir?
I'm okay, Chief.
We thank God. You sent 2 emails each with attachment. Which one do you want me to review?
The second one.
understand?
Mm.
We'll give them that thermometer. So they should know the NHIS drugs that are in the pharmacy
Mhm.
that are in stock, so that they can use that, because when that it's a lot.
Mm.
Because you see that this medicine is out, but the diagnosis is still there. And when it goes to them, they'll
Yeah.
Hello, Isaac.
So I don't
Hello,
know how we
Isaac.
Hello.
Hi, Isaac.
Sorry. Hello.
Hello, my name is Ajua of NHI. Please, your name,
Sorry.
please.
I'm Isaac.
Oh, welcome, Isaac. Unfortunately, we are done with the training.
Yes.
But there will be another.
Please, I was at the session. I just stood up just a short while, so before I.
Oh, okay. Oh, okay.
Yeah.
Okay. Can
So
you tell your other colleagues to join on 21st? Okay. Everybody should
21st.
have this. Hasn't it been
21st September.
21st September? Yes.
Oh, okay. Please, how would we get the link?